tests available on the visual field, but I will be basically talking to you about these two, the 30-2 and the 24-2. The same principles go for the 10-2 too. So when you're doing a 30-2 or a 24-2 test, how do you make out that, know that it is a 30-2 or a 24-2? Well, it's very simple. It's written over there and it's also marked out over there. And this is a 24-2 because you can see that the points are not tested till 30 degrees. And a 30-2 typically looks like it's completely symmetrical, while a 24-2 looks more oblong on one side. You divide this entire visual field into these 8 zones. Zone 1, Zone 2. Zone 2 also has a Zone 2A there. Zone 3, Zone 4, Zone 5, 6, 7, and 8. And I'll walk you through how you do each of this. So the first question that you have to ask yourself is whether there is a visual field defect. And in order to do that, you need to go through all these zones one at a time. So the Zone 1 contains some important information in terms of test type and strategy that we had shown you that it was a 24-2. And in addition, it has a name, the age. The age is very important in the visual field because a visual field is compared to a normative database, which is age matched. Then you have the correction used, and typically if the correction is less than or equal to 1 dioptrosphere, you can ignore it. Beyond that, it needs to be corrected. You also have information regarding stimulus size and pupils. In the interest of completion, I'll tell you a little bit about stimulus sizes. There are 5 stimulus sizes, and there are different stimulus colors available on the visual field, depending on the machine that you use. But typically for a standard field, you would use target and white stimulus. It's important that you know that the size 3 target is about 4 millimeters squared in area, while a size 5 target is 64 square millimeters in area. So it's a huge difference between a size 3 and a size 5. And this is a representation of the blind spot. And you can see that this is the size of a size 5 in relation to the blind spot. And this is the size of a size 3 in relation to the blind spot. This has a little relevance, which we will come to later. In terms of fixation targets, or where the patient looks at the time that the visual field is being performed, you have 3. You have a central, a small diamond, and a large diamond. So you basically show, this is the central point, which is what most fields would be used for testing. Now, suppose the visual acuity is very poor, or you have a central scotoma, and the patient cannot actually see the center, then you would ask them to look between these 4 small lights. And this is called the small diamond. If there's a large central scotoma, then you ask them to look between these 4 dark points, and that is the large diamond. So the Zone 1 gives you information as to the type of threshold, the type of stimulus, and where the fixation has been. In terms of strategy, you have full threshold, Sita standard, Sita fast, and now Sita faster. I'm going to talk to you mostly about Sita standard. I will talk to you a little bit about full threshold because I understand that some people still use that quite widely. So coming back to Zone 1, you also have information regarding the eye, the correction used, the stimulus size, and the pupil. We spoke about correction and stimulus size. Let's now just take a quick look at these 2 fields. Now these 2 fields look a little different from each other. One is the left eye and the other is the right eye. And this, unfortunately, is somebody who was tested in the right eye as a left eye field. So the right eye was tested after entering left in the chart, in the machine, and that's why you're getting 2 areas of depressed threshold here, and you're getting a blind spot in this area which the machine has decided to mark out. So when you do the field with the eye correctly marked, you get a very different visual field from what you do on that side. So these mistakes do happen when you're doing a large number of fields, and it's important that you look at the data and make sure that it is the correct data. In terms of coming back to Zone 1, the other thing that we need to look at is pupil diameter. So if you look at this visual field, you can see that there's a fair amount of peripheral defects there, and they're much less over here. And this is because this was done with a 2.1 millimeter pupil, and this was done with a 5.5 millimeter pupil. When you're doing visual fields, you should use at least a 3 millimeter pupil size in order to do a field. Otherwise, you can get additional edge defects. And suppose you're doing the visual fields dilated, it's always a good idea on follow-up to continue to do it dilated, because there can be some variation between a dilated versus a non-dilated pupil. Zone 2 contains useful information like your reliability indices and the 4-wheel threshold. So your reliability indices include the fixation monitor, blind spot, which we'll come to a little later, the fixation target, which we spoke about, central small diamond or large diamond, the false positive and the false negative errors. Fixation losses are traditionally checked by this technique called the Heil-Krakow method. And what it does is, in the beginning, the machine plots what your focal threshold is. It also maps out where your blind spot is. In between, it sends you a supra threshold, a bright stimulus. It flashes it at the blind spot. And if you respond to it, they know that the eye has moved out. And that's how it checks fixation losses, because traditionally this spot is much smaller than the blind spot. You would not be able to see it. There's also one more little bit, the 2A zone 2A, which I showed you, which is the gaze tracking. And the newer, the Sita Faster in fact uses only gaze tracking. And what you have over here is, it looks at the corneal center, and it tracks the position of the corneal reflex and looks for displacement from the center and maps this all through the field. So what you get is this little worm at the bottom of the printout. Upward spikes basically tell you that the patient has lost fixation, and downward spikes are blinked. So downward spikes are expected. Upward spikes are not necessarily a good thing. A few upward spikes are not unusual, but a lot of upward spikes means the patient has been looking around all the time and not really been paying attention. So look at these two visual fields. Now this is somebody with 0 out of 14 fixation losses, and this is somebody with 1 out of 17 fixation losses. And what you're seeing over here is basically, look at this track versus this track. So this is an absolutely nicely done field with hardly any fixation deviations from the central fixation. While here, even though the fixation losses are few, you can make out that the person has been looking all over the place, and therefore this field is definitely more unreliable than this field. What about false positives? So false positives are basically a response to a fake stimulus. So what happens is, suppose you press the button in response to all the sounds that the machine makes, that is recorded as a false positive. In Sita, if you press the button in a phase when the machine is not expecting you to press anything, that is considered to be a false positive. So this is the way Sita tests. So this is the way the stimuli are shown at intervals. And this, so when you show a stimulus here, this period is the period when you don't expect to see a response, because that is too short for the reflex arc to happen for you to see the stimulus and press the button. So if you respond in this phase, this is called a false positive. A false negative, what happens is, at a known normal point, which you have tested before, you show significantly brighter stimulus. If you don't respond at that time, this is recorded as a false negative, because you are expected to respond at a point that you have seen before. But false negatives are a little more tricky, because when you have glaucoma, you can have false negatives, because there is more variability in the glaucoma field, and thresholds can fluctuate within the test itself. So we pay less attention to the false negatives from a reliability point of view than we do with false positives. Reliability is also influenced by age, disease, fatigue effect, the learning curve of a patient, and the type of test. The longer the test, the less reliable it's likely to be, just because of fatigue. The third thing that we look at is the gray zone. We actually don't look at it, because this gray zone, gray scale, is basically just an artistic interpretation of the field. It is useful for detecting artifacts. And my good friend Mike Patella, who is one of the designers of the Humphrey machine, says that you should use it to keep your coffee cup on, because you don't have to pay any more attention to it once you rule out the artifacts. We'll come to zone 4 now, and zone 4 is this, and this is the total deviation plot, and let's talk a little bit about that. So zone 4, essentially what you're doing over here, it has two portions. It has a top portion, which is the numerical scale, and it has a bottom portion, which is a statistical representation of the numerical scale. So what you're seeing over here is, you can see that each of these points is given a value. And these values are basically how much this point differs from the age-related normative database that the machine has. So at this point, the threshold is exactly what it was expected. At this point, it is 3 decibels less than what was expected for this age and this location. At this point, it's 25 decibels less than what was expected for this age and this location. So it's important to pay attention to this number and the pattern of stimuli here. So each of these stimuli is then classified depending on the degree of abnormality. And this is classified using this scale. So if the stimulus is so depressed, if this point is so depressed that this sort of depression would be expected to be seen in less than 0.5% of normal individuals. You get this entire big black square. If on the other hand, the point was depressed to a level that you would see in less than 1% of normal people, you would see this type of a pattern. If it is what you see in less than 2% of people, this is what you would see. And if it is less than 0.5% of people, you would see this sort of 4 gray dots. And if it is within the normal expected part, you will see just a dot there. And this scale is shown at the bottom of the meter. And this is what actually you pay good money for, because this normative database is what tells you how important this field defect is in this patient. So when you look at the hill of vision, and this is just a representation of the hill of vision. So this is the actual hill of vision, and that is the threshold that is measured. This is your blind spot, and that's why you have a sort of well going all the way down. This is threshold on the scale. So when you look at the total deviation plot, there are many factors that can reduce the overall sensitivity. For example, cataract can reduce it, a small pupil can reduce it, a central corneal scar can reduce it, uncorrected refractive error can reduce it. Even if you have just done applanation and gonioscopy and the central cornea has got a number of SPKs on it, that can cause a reduction. So what would happen then is that the hill would get depressed. This is the actual threshold of the patient, but because of the cataract, you cannot see that dimmer stimulus. You are able to see only brighter stimuli, and therefore the hill of vision is depressed. And this is challenging because glaucoma occurs in the same age group as people develop cataract and other age-related issues, miosis. So we need to be able to differentiate generalized depression from a visual field defect, because if you have a visual field defect like this and you have generalized depression, you may miss the visual field defect because the entire field is depressed. And that's why you have zone 5, which is the pattern deviation plot. So zone 5 again has 2 portions. So this is the total deviation, this is the pattern deviation. Zone 5 again has a numerical portion and it has a statistical portion. So what you have over here is essentially, it shows you focal defects after adjusting for overall sinking or elevation of the hill of vision. So what does this mean? So if you ever go hiking in a mountainous area, then which is snowbound, then one of the problems that you have is that you have these hidden crevasses in the snow, which may be completely covered. So you would not know that this hides this sort of a crevasse because that snow has formed a layer on top of it. And so typically mountaineers will use an instrument to poke through the snow in front of them to explore it for these sort of cavities, because once you step on it, you can fall. So that is similar to what the visual field does. It assumes that that a certain amount of depression is because of generalized reduction in sensitivity. And this certain amount is basically the 7th most sensitive point. It'll look at the 7th most sensitive point, and then it will say, that much of reduction I expect throughout the field. Let me take out that much of reduction and see whether there are any points hiding below that. And so here, where you have a number of points scattered all over the place, you'll end up revealing a smaller localized defect which was hiding under the generalized depression. So this is what your generalized depression looks like with a localized scotoma. Once you have corrected for it, you are reducing this generalized depression down here, and you can then detect the localized scotoma there. And the pattern deviation plot is really important when you have any sort of generalized depression in the field. If you have no generalized depression in the field, the pattern deviation and the total deviation plots will look very similar. We'll move next to the global indices, and the global indices are all the points. And this is basically zone 6. This is all the information from all the points tested, which is reduced to a single number. And the 2 things that we're interested here are the mean deviation, the pattern deviation. I'll talk a little bit about short-term fluctuation and CPST in case you're using the older threshold version. And I'll also talk about the visual field index. So the first thing that we come to is the mean deviation. So the mean deviation is derived from the total deviation plot. And basically what it tells you what the average deviation of each point is from the age-corrected normative database. And in general, most of the time, the values will be negative because those thresholds will be less than what you will see in a normal patient. They can occasionally be positive, which means this person actually has a better threshold sensitivity than what you would see in a normal person. So positive numbers indicate that it's better than normal, and negative numbers indicate that it's worse than normal. This is a single value which tells you generally overall how the mean deviation is, and mean deviation can go from 0 to about -30 on the negative side. -30 is a completely extinguished field. You also have the visual field index, which we'll talk about now. So the visual field index basically is a single value that represents the entire visual field as a single percentage of normal. It's based largely on the pattern deviation plot, which we'll cover after this, and it is weighted for central points. And in order to make life easy for us, it goes from 100% to 0. So the full visual field on the has a VFI of 100%, while a perimetrically blind visual field has a VFI of 0%. And it's relatively independent of the effects of cataract and other media opacities, which can affect your mean deviation. And therefore, it reflects localized damage better in glaucoma. I told you that central points are weighted more than peripheral points. And here you have a visual field with more central points affected. And you can see that the VFI is significantly lower than this visual field, which has similar number of points affected, but fewer central locations. Okay, I'll just talk to you about pattern deviation. I think for some reason the slides are not showing up. So pattern deviation, the pattern standard deviation value the pattern standard deviation value basically tells you how much variability there is in the visual field. Because we had decided here that the mean deviation tells you what is the average deviation from the age-corrected normative data. The pattern standard deviation tells you how much variability there is within the visual field, because the pattern standard deviation is trying to pick up localized effects. So it's actually a measure of the standard deviation of the thresholds across the field. And the pattern standard deviation behaves a little differently from mean deviation. Mean deviation, I told you, goes from 0 to -30. The pattern deviation goes from 0 to about 30, but it is valuable for us only in the first half of it. I'll tell you why. We next come to zone 8, which is the actual threshold values. And here you look at the actual threshold values. We don't typically look at it except in some situations. For example, you look at this field and you want to compare it with any other field. So when you're comparing two fields, you might want to look at the threshold values to see whether there's a difference between the two fields. If you see something like this, with large white areas there, you can look there to see what is happening, and you're seeing that there are some points which are 50 decibels and 49 decibels there. So these are really abnormally high sensitivities, because you never get this sort of sensitivity even at the center. So you look at the actual threshold values when you want to look for an abnormality, something which is unusual, very unusual on the field. Otherwise, or when you want to compare one point as compared to before, but otherwise typically you don't look at it all that commonly. You next come to the glaucoma hemifield test, which is given just below your reliability. This is just above your reliability indices. And this is again an important part of the visual field, because it tells you how much symmetry there is in the visual field. Most of the time, visual fields are asymmetric in glaucoma. So what it does is it tests these 5 zones. So these 3 points here, these 4 points constitute one zone, these 5 points constitute another zone, these 6 points, one more zone, and this 4 points, the 5th zone. So each of these zones is compared to a mirror image zone on the other side. And then you try and see whether these are classified as outside normal limits, where you would see this amount of variation in less than 1% of eyes, borderline, where you would see this sort of difference between both the hemifields less than 3% of the time, generalized reduction of sensitivity where the whole field is depressed, and abnormal high sensitivity. It is the most specific single criterion for glaucoma, because this sort of asymmetric horizontal midline fields are typically seen with glaucoma. So this is an example of a visual field with a P less than 1%. On glaucoma, hemifield test is outside normal limits, and you can see the entire visual field is very significantly depressed in the superior hemifield. The inferior hemifield is nearly normal. Borderline, here you can see just a few points in the superior hemifield are affected, while the inferior hemifield is normal, and this is what a borderline would look like. And this is the same example that I gave you before, where you can see this white scotomas where abnormally high sensitivity is there, and the glaucoma hemifield test will tell you that there is abnormally high sensitivity. When you look at a visual field, in order to decide whether the defect is glaucomatous or not, we have what we call Anderson's criteria, which has 3 criteria. The first one is there's a cluster of 3 or more non-edge points in a location typical for glaucoma, all of which are depressed on the pattern deviation plot at the p less than 5% level, and one of which is depressed, at least one of which is depressed at the p less than 1% level. So on a 30-2, you don't take edge points. On a 24-2, you include edge points. This can be combined with a CPST or a PSD that occurs in less than 5% of normal fields on 2 consecutive fields, and or a glaucoma hemifield test outside normal limits on 2 consecutive fields. So basically, let us look at this visual field and see what all do we have here. So what we have over here is we have a field which is reliable. There is some amount of gaze issues on the gaze tracker, but it's not too bad. And you're seeing a superior aquate defect which is very symmetrical on the total deviation and pattern deviation plot. We are seeing a glaucoma hemifield test outside normal limits, which is one of the criteria. And when we look at the pattern deviation plot, we are seeing definitely a cluster of 3 or more points, all of which are depressed to a level seen to p less than 5%, and at least one of which is depressed to a level of p less than 1%. So you have a cluster of 3 or more Moneesh points. You have a mean deviation which is depressed to a level seen less than 1%, and you have a glaucoma hemifield test which is abnormal. So it meets all 3 criteria for a glaucoma hemifield, for a visual field abnormality. So what about this? So if you look at this visual field actually meets again all 3 criteria. The glaucoma hemifield test is outside normal limits, the PSD is depressed to p less than 0.5%, and you have a cluster of more than 3 non-edge points which are depressed as per Anderson's criteria. So this definitely looks glaucomatous as per Anderson's criteria, but when you repeat the visual field, it actually does not meet all the criteria because you have just about 3 points there. PSD is still abnormal, GHT is outside normal limits, but the 3 definite criteria which are positive here are not really positive there. And that's the reason you need to be able to, in addition to saying that the field is reliable, you need to be able to see that it is repeatable. So visual field defect, once you establish that is there, you have to establish that it's reliable and you have to establish that it is repeatable. So now this was somebody who came to us with an asymmetrical cupping, a normal looking fundus otherwise, but the field was looking like this. On repeating, look at the false negatives, 99%. On repeating, this is probably because the patient was not instructed properly. You go to a false negative of 69% and you see this sort of pattern which we call a cloverleaf pattern, because typically you start testing in these 4 locations first. So the patient has paid some attention in the beginning and done those 4 locations well and then forgotten for the rest of the field. So this is a type of cloverleaf test, and just look at the gaze tracking pattern. The patient is looking all over the place. We repeat it again. This time false negatives are down to 7%. Gaze tracking behavior is better, but still losing attention. And this field is absolutely normal. So in order to be able to confirm a visual field, you need to be able to repeat it. And don't forget that there is a learning curve on visual fields, and most of our glaucoma patients will have some amount of learning field. What about further information? Do you need further information? And for that, you have additional options available to us. And one of the questions that we get asked is, when should you consider 10-2 testing? So when you look at this visual field, there's a dense superior aquate defect there, there are biaquate defects here too, and you have defects which are adjacent to fixation. When you have defects which are adjacent to fixation, it makes sense to do the 10-2. And the 10-2 looks like this. You'll have a 10 there. You will not have a blind spot because a blind spot falls outside this, and you have a symmetrical field printout. And this basically test points because 2 degrees away from fixation instead of 6 degrees away from fixation. So you get a much more detailed follow-up of the central field. And somebody with a defect like this, you should follow up with both the 24-2 and the 10-2, because increasing damage on the 10-2 will require more aggressive treatment since it's close to fixation. The pattern deviation plot is sometimes of no use, and it's because of this reason. So in the older versions of the machine, in very advanced damage, sometimes the pattern deviation plot would look normal and the total deviation plot would look completely abnormal. This is because the pattern, once you have corrected for the 7th least depressed points on the pattern deviation plot, all the points may be depressed to that level or greater. So you don't see any defects there. So this has been corrected in the newer versions of the machines, where it will give you a message saying pattern deviation is not shown for very severely depressed points. What can you do when you have that type of a field? You can use a size 5 stimulus. That is, if the fields are very constricted with very few central points, you can use a brighter stimulus and come up with so this is something with a stimulus size 3, and you move to a stimulus size 5, you definitely get more points which are okay. But this does not give you a normative database. You get a normative database, but you don't get any statistical information. You will have to do a point-wise comparison for the future, but you can do this both the visual acuity is poor or you have very advanced damage. And it's a little more painstaking because you have to do follow-up based on actual thresholds. You can also do a macular threshold where you just test these 16 points. Each point is tested twice. You can do this with a size 3 if the defects are damage is not very significant, or you can do it with a size 5 if you have very significant damage. So when you do interpret a visual field, you have to establish that there's a visual field defect. You have to establish that it's reliable. You have to establish that it's repeatable. Then we come to this 35-year-old man who complains of a headache. And when he comes to you like this and you look at a field which looks like this, you immediately get concerned and wonder whether you should image him. But again, you repeat it and you find the field is normal. So sometimes even a classical pattern will disappear when you just repeat the field. And this is the last patient that I have. This was a patient with a family history of glaucoma, diagnosed elsewhere to be a glaucoma suspect with an intraocular pressure of 20 millimeters of mercury. We did the visual fields which look like this. The optic disc was okay, maybe a little bit of thinning here, but really we could not match it to this visual field. And when we took a closer look at the fundus, you can see an old vessel occlusion there. And that was the reason for the field defect. So just because there's a field defect, it does not necessarily mean that it's because of glaucoma. And you have to interpret visual fields in completion, in an entirety with the patient's clinical picture before deciding that it's because of glaucoma and starting on treatment. Thank you.
Thank you, sir. I think it was lovely. We have some very interesting questions also. You covered almost everything about the interpretation of visual field. I too also have some questions we'll ask later on, but I'll just first cover the questions by the participants. There's one question that what is the difference between Sita and Sita fast?
Okay, so Sita fast is basically a faster algorithm. Instead of testing threshold twice on each time, it sort of guesses at the threshold. So if you have done if you have done the fields before, it'll look at 4 points around which the 5th point, which is adjacent to that, it might just put on a threshold which is close to what is accepted and test once. So it will not do double thresholding every time. It helps to do the testing faster. The problems that you have with the Sita faster are that if it's the first time that you're doing a field, it's actually a little bit more difficult to do than when you're doing a traditional Sita standard. But it's much, much faster. In fact, the newest program is hardly 1.5 minutes.
It's very quick and easy also for the patient. So another question is, what is short-term fluctuation, and related to that, what is the difference between PSD and CPSD?
Okay, I actually missed those slides in between. I think I don't know where they went, but yeah. So short-term fluctuation. I told you when I was speaking about false negatives that you have got a point which you saw before, and then you show a stimulus which is 9 decibels brighter, and sometimes patients don't see it, and that's because of fluctuation within a visual field. And this is called short-term fluctuation. So within a visual field, when you have fluctuation, when you're testing points repeatedly, that is what's called short-term fluctuation. And in the full threshold program, because it can take up to 9 to 10 minutes per eye, there is a greater risk of a short-term fluctuation. So you had 6 points which were thresholded, 8 points which are thresholded twice. And it would look at the standard deviation between each of the tests at each location and use that to correct the pattern standard deviation value to give you a corrected pattern standard deviation value. So if you had hardly any short-term fluctuations, PSD and CPSD were very similar. If you had a lot of short-term fluctuations, CPSD is the value that you would need to use.
So there's another question. What are the edge and non-edge points on Anderson criteria for glaucoma?
Yeah, so basically when you do a 30-2 test, all the points, the most peripheral points are the edge points. So on a 24-2, and if Anderson's criteria say that you don't use the edge points except in the nasal hemifield, because that's where you get the nasal step. So in the nasal hemifield, you would include edge points too. When you do the 24-2, you are immediately removing all the edge points except in the nasal region. So in a 30-2, you exclude the edge points. In a 24-2, you don't exclude anything. Maneesh, your mic is muted.
Any minimum age or any visual acuity for undergoing field test?
You can do a visual field test with the standard visual field up to 636, occasionally even 660. But in general, 618, 624, you can comfortably do it. Younger stage, I've even had 8 and 9-year-old children doing it. But because now with the video games, they're pretty good at it. The problem is that the normative database starts from the age of 18. So when you're doing it with an 8 or 9-year-old, you're actually comparing them with an 18-year-old's thresholds.
So I think it depends more on the alertness and intelligence of the patient rather than actually the age number.
Yes.
So one more thing, a lot of time there is a confusion for a glaucoma patient, whether we should do a 24-2 or 30-2, because some people do 24, some do 30. So what should you? So
in an ideal world, it would be good to do 30 because you get a little bit more information. But then when you look at Anderson's criteria, anyway, you're going to ignore the edge points. So you're fairly, you're happier doing a 24-2. It saves you time. It saves your perimetrist time. It also is less fatiguing for the patient. So a 24-2 is fairly reasonable to do in a glaucoma patient. In a neurologic patient, you would definitely prefer to do a 30-2.
So there's another question. What is macular split and how to see macular split?
Okay. When I showed you the macular thresholds in the towards the latter half of the presentation. So basically, when you look at the thresholds, you have a vertical hemifield and you have a horizontal hemifield. If any of the points next to the junction of the vertical to the center basically has 0 decibels, that is called a macular split. Macular split was traditionally defined as being seen with a size 5 stimulus on the macular threshold program. But nowadays we tend to consider a macular threshold split as being a 0 decibel point on a 10-2 or a macular threshold. So it's not, the significance of this is basically in the original papers with a macular split, they predicted that the risk of a wipeout following glaucoma surgery in somebody with a macular split is around 2%. There is more recent information, both from Shankar Netralaya and other places, which say the risk may not be as high as we thought, but it is something that we need to warn our patients with advanced damage about.
So, sir, even on a 10-2, if one of the center 4 points is 0, we'll sort of consider it as a macular split.
Even on a 10-2, because a 10-2 also tests essentially the same points as a macular threshold, 1 degree away from fixation.
So there's a question which oftenly asked in Viva exams that what is different between 24-2 and 24-1? So what is this -2 and -1 something?
When I showed you a cartoon of how the stimuli are presented.
Yeah, on the 2 sides.
2 axes on both sides. So 24-2 basically straddles the midline. So you have points on both sides of the midline, both horizontal and vertical. In a -1, you actually test on the midline. So the problem with a -1 is if you're looking at a neurological field, you may miss it because since you're testing on the midline, it may not show you a classic midline defect. So typically for all practical purposes, we use a -2 program.
How do you classify mild, moderate, severe glaucoma based on perimetry?
So based on perimetry, there are multiple classifications that you can use. What is traditionally used is the Paddock, Anderson, and Parrish classification. Very briefly, mild is a mean deviation of less than -6 decibels. Moderate is between -6 and -12, and severe is more than -12.
And the last question is please tell something about glaucoma progression analysis. So something a little bit what you use in your practice for seeing progression.
Yeah, so I use the guided progression analysis, which is the software which comes within the machine. And essentially, I showed you all this about a visual field. So now you've got 70 odd points on a field. And when you're looking at progression, you have to see how each point is doing in comparison with the earlier points. So it's very difficult to just look at it and decide whether it's getting better or worse. It's better that if you use a statistical software, which will compare each point and which will compare that with what is expected to be seen in a glaucoma patient. And when some of your programs will even predict how much worsening you can see. So typically for any good progression analysis, you require about 4 to 5 fields. You require 2 good baseline fields. And I would strongly encourage that you use the software in the machine to do this.
So how many field you do normally for a newly diagnosed patient over a period of say 2 years?
So I would prefer to do the first 2 fields within, ideally very, very early within the first month itself, but typically probably within the first two to 3 months. And I would like to do at least 5 to 6 fields in the first 2 years, because you need to find out at what rate this patient is progressing. And it's important that you tell them when the first time they come to you itself that this is what the plan is.
So one other question, actually I have a lot of time now, we get question that there are many different machines available. For example, like Octopus or even Indian companies are there. So a lot of people want to know whether the reports of these machines can be comparable. That point you've already covered in your presentation. So what is the ideal thing? Should we stick to Humphrey, or we can have other perimetry machines also?
See, the 2 machines or the 3 machines with well-known normative databases are the Humphrey, the Octopus, and possibly the Magnot. Any machine can actually give you a threshold value. What you need to know is how consistent is that threshold value, how good is the normative database, and glaucoma is not about diagnosis. It's about following up these patients for your lifetime. How good is the progression software? So if you have any serious glaucoma practice, use one of the standard machines. It doesn't make sense to buy anything else. If you just want to look at a visual field pattern or neurological field, then probably any field will do.
But then we have to follow up it on the same machine. We can't like switch from one machine to another. I think so this is, we have one last question. Do you use contact? Do you consider using contact lens for any patients with high myopia or high hyperopia when you're doing perimetry?
So when you grow beyond maybe 5 to 6 diopters, if you just put a corrective lens, you can get edge artifacts because of the thickness of the lens itself and the distortion. So in that situation, you're better off using a contact lens because with the contact lens, those artifacts don't happen. I didn't show you an example of that in the interest of time.
Thank you, sir. I think we have covered most of the questions. We'll take any other question if we have in the second part of the presentation. And Dr. Julie is already ready.
Yes.
Dr. Julie will be presenting on difference between glaucomatous and non-glaucomatous optic neuropathy. The sir will back again after the presentation. Dr. Julie, as you all know, is a senior consultant at Shroff Hospital. Dr. Satyajit?
Thank you, Dr. Ronnie George, for the beautiful presentation. Now we'll move on to the next paper, which is by Dr. Julie Pegu, who is a consultant of glaucoma and anterior segment at Shroff Charity Eye Hospital. Dr. Julie Pegu has done her MBBS from Guwahati Medical College and her MS from Assam Medical College. She has done her fellowship in glaucoma and anterior segment from Dr. Shroff Charity Eye Hospital, New Delhi. She has more than 10 years of experience in the field of glaucoma and anterior segment diseases. She is an expert in cataract surgery and has extensive experience in managing complicated cataract surgery. She is also acknowledged for her proficiency in doing complex glaucoma surgeries and has a special interest in management of pediatric glaucoma. She is a passionate trainer in cataract and glaucoma surgeries and is an eminent speaker in state and national conferences. She has published more than 25 research papers and believes in collaboration and dialogue with peers, as well as contributing to the domain with her knowledge and understanding, while simultaneously staying updated about the current advancements in her field of work. She is amicable, honest, hardworking person with deep interest and dedication towards the patient's welfare. Presently, Dr. Julie Pegu is associated with Shroff Charity Eye Hospital as a senior consultant in the Department of Glaucoma. Dr. Julie Pegu, please.
Hello, Dr. Julie. I think we can see your slides, so we can start your presentation and then we'll discuss the questions after the presentation. Yeah, is this your screen? Yeah. We can see.
You can minimize this one and then pick up your PowerPoint.
Yeah, this is fine. This is fine.
Perfect.
I thank the organizers for inviting me to this webinar. I mean, it's a pleasure to be amongst all of you. I'll be talking about differentiating glaucomatous from non-glaucomatous optic neuropathy. I'm really excited whenever I see new glaucoma patient because because every optic nerve is different, and so you have these challenges to diagnose glaucomatous from a non-glaucomatous optic neuropathy. So you can see that these are pictures of normal optic disc, but they all look different. So definitely there are criteria which would really help us in deciding which optic disc has glaucomatous features. So the first thing I do when I see an eye is I always dilate them, because that is the way that you get maximum information from the patient. So, and the first thing that I see when I'm examining a patient is what is the size of the optic disc, whether it's a small, medium, or large optic disc, because all of us, we know that a small optic disc may not have the cup can be very small and be normal, whereas a large optic disc can have a large cup and still be normal. So how to establish the borders of the optic disc? So this is the peripapillary scleral ring, which is not a part of the evaluation. So please, whenever you are seeing an optic disc, just exclude that out. And the area which is inside this margin is the actual optic disc. So how do we measure the optic disc? We measure the slit lamp reticule multiplied by the correction factor. So you make a thin beam of slit and you measure from the edges of the little ring. And because I use a 90 diopter lens, so I multiply it by 1.3. And so you can see that that the medium optic disc has a huge variation. It can be towards a smaller size and a larger size. So for simplicity, what I do in my clinic is that when the optic disc size is towards the small optic disc, and I write MS, so that it just tells me that it is a medium optic disc but towards a smaller size. And when it is towards 2, then I write M, which means that it is a optic disc. It's a medium in size, but it's towards a larger size, because it is the size of the optic disc that is important to us. So coverage ratio is something that is universal. Everyone does it. And the maximum coverage ratio can be 1:1. What I like to do is the rim disc ratio. It is actually the rim which is important and gets affected in glaucoma. And so the mini quadrant, the maximum rim which is present is 0.5. So suppose this is the optic nerve. The coverage ratio is 1:1, but it is best to tell it in terms of rim disc ratio. So if I have to describe this disc, and then I can say that the rim disc ratio is 0.15:1, which is present nasally, and in the rest of the quadrants there's no rim. Suppose this patient is lost to follow and the patient comes back to us 3 or 6 months later, and we see that the rim is actually down to 0.01:1 nasally. In the clinic itself, it is easy for us to quantify as to what is the rate of progression and how fast the patient has progressed. So similarly, you can do this rim disc ratio in any quadrant, and it actually makes you look at the rim so carefully, so that if there is any change in any of the quadrant, it is you can note that change. Last but not the least, what is most important is the retinal fiber evaluation. It is so it is this evaluation that tells you whether it separates a patient who may have glaucoma or who may not have glaucoma from the early glaucoma, from the glaucoma suspects to early glaucoma. So these are seen as bright and fine striations, and they represent tissue canals in which processes of the molar cells gather the axons together into bundles of 20 microns. They are usually seen vibrantly in the supratemporal and region, which is important to us because it is the poles which gets affected in glaucoma first. It is thinner in the nasal and the temporal quadrant, like 1 axon per bundle, and that is why it is not visible to us. So whenever you see that any area of neuroretinal rim thinning, you also see the corresponding RNFL defect. So in this case, because there is bipolar thinning of the neuroretinal rim, and you see that there is beautiful wedge defect that has formed, and any defect is seen as a dark area. You can also appreciate that in the red free light and in the black and white pictures. So it is in the early and the moderate glaucoma where you get a pattern to the RNFL loss, but whenever there is a diffuse loss of the neuroretinal rim, like in very advanced glaucoma, there is no pattern to it. Okay, you don't see a pattern because there's a diffuse loss of the retinal fiber layer, and you see the vessels standing out. So initially, how did I start? When I started, one tip I would like to give out is that, dilate all normal patients, at least 500 normal patients, where you get to see a good NRR and you see how the RNFL looks like. So that way, when you come across a patient where there is something on the neuroretinal rim and you are trying to appreciate the RNFL, then you can make out that the RNFL, that there is RNFL loss. So I'll be discussing a few cases with you. So this is a 42-year-old male where the pressures are 18 and 20 with open angles. And you can see that, both the optic discs are small in size. So in the right optic disc, you can see that, there is a regular margin of the cup, and the cup is around 0.3:1, which is not expected in a small disc like this. You can also see that the cup is also getting slightly deeper, which is not normal for a disc like this. You can see this by the bending of the blood vessel. But when you go and see the RNFL, you can see that the RNFL still looks intact. But if you go to the periphery and see, you can probably make out that, there's some RNFL loss that's happening in the periphery, but which has not reached to the optic disc as yet. So definitely this eye is has glaucoma suspect, is a glaucoma suspect patient. But I always thank God for the two eyes that we have, so that you have the other eye for comparison. So if you look at the left eye, you can see that the cupping is much more in this eye. The rim disc ratio is around 0.01:1 inferiorly. And when you look at the RNFL, you can see that superiorly, where the neuroretinal rim is good enough, the RNFL is also vibrant and it's full, you don't see any defect. But inferiorly, when you look for the RNFL, you see that there is a diffuse loss. So you can also see the diffuse loss here. So definitely this patient has glaucoma and needs treatment, and that the left eye is more severely affected than the right eye. So in this case, if for the right eye you're not going to start any treatment, you can keep it under observation. But this eye definitely will end up showing some defects later on in the coming time. So this is one of my favorite patients. She's a 51-year-old lady gynecologist, and she always had pressures checked multiple times in the high teens. She never went beyond 20. She had open angles, and then if you look at her disc, the disc looked pretty healthy. There's some tilt of the optic disc, but if you look at the neuroretinal rim, it looks pretty healthy, and it's a large optic disc. But when you dilate and see, you can see that there is a nice RNFL defect which is formed inferiorly, and this is very, very typical of a glaucomatous damage. So in this case, the fields were definitely, normal, and the OCT was showing some yellow changes inferiorly. But whenever you see a defect like this, at least you are confident that, this patient is definitely having early damage, and you can discuss the management protocol with the patient. Similarly, to detect an RNFL loss, you have to concentrate wherever you feel that, that my neuroretinal rim is going thin. Like in this patient, it's a large optic disc. You can see some beta changes, and the pressures were definitely a little high for this patient. And when you see the neuroretinal rim here and you see the RNFL, you can see that inferiorly it is. But superiorly, you see that the RNFL stripes are minimal, and then here you can appreciate the defect. So, so that is how it helps us. So this is a 42-year-old male who has got some amount of cataract in both the eyes, the vision being 612 and 618. Again, if you just look at the optic disc, it's a medium optic disc, and the neuroretinal rim is fairly looking okay with a rim disc ratio of 0.2:1 and a CD ratio of maybe 0.7. But this kind of disc, if you do not dilate and look at for the RNFL, you may miss out the early loss. So in this patient, you can see that there's a localized RNFL defect which is formed here. And in the left eye, if you see that the damage is definitely much more, you can see that, there's hardly any rim in this quadrant. Nasally, you can see that the rim is 0.15:1, and there is a diffuse loss, RNFL loss in both superior and inferior quadrants. The patient also has some has BRVO superiorly. So maybe these are the patients where even if the pressures are 20 and the disc may look healthy, but if this RNFL has formed, then you know that early damage has started to happen and you might want to treat this patient. Similarly, this is a 40-year-old male who has a family history of glaucoma. And if you just look at the optic disc, now this optic disc, the optic discs are medium in size and they were looking healthy enough. Even the cup is not very deep. So, but if you look beyond optic disc in a dilated examination, then you can appreciate this RNFL defect which has started to form here. So obviously when you see a sign like this, do not take it lightly. On the other hand, you know, this obviously this the left eye has more cupping than the right eye. It's around 0.7:1, and there's a thinning happening which is inferiorly. And when you look for the RNFL, you see that the superiorly it is okay, but inferiorly you see a wedge defect. So similarly, it is being shown here. So this is a 45-year-old female and she was labeled as a disc suspect elsewhere, and the pressures were again 16 and 19, not much. I mean, it is mid to high teens. And when you dilate this patient, you see that the right eye has got, the RNFL is pretty okay intact, but in the left eye, if you see, you can see that there is thinning of the new retinal rim here, and corresponding to which you can see this nice defect that is formed. So I think you should direct your concentration to any area of neuroretinal thinning, and corresponding to which, if you get an RNFL defect, I mean, those are very characteristics of glaucoma. And you can exactly say that, you know, I'm having more damage in this area. And also by just looking at this optic disc, you should be able to predict what kind of visual fields I'm going to get. Like in this patient, because of this notch that is forming here, you'll be definitely expecting a superior arcuate scotoma or an incomplete arcuate scotoma. Whereas superiorly, you can see that RNFL is still okay. So, you know, you may not get anything in the inferior visual field. So like this, so superiorly, so in the left eye, you are getting an arcuate scotoma, but inferiorly, I mean, wherever, I mean, the disc definitely looks that, you know, that the margin are getting more distinct, but still because of the intact RNFL, you also don't get any field changes. So you should be able to predict, you know, the kind of visual field and OCD that you're going to get by looking at the optic disc. And it should not be reversed that, you know, in the disc you're not getting any findings, but the field is showing something, so this patient must be having glaucoma. It's not like that. It should always be a clinical examination of the optic disc where you are definitely getting a thinning with the corresponding RNFL defect, and then you are predicting the field. It is difficult in myopic eyes where the disc is tilted, torted. But in this case, if you see this patient, because of the optic disc tilt, one edge of the side to which the optic disc tilt happens, there the stellar ring is thin. On the other hand, the other side is lifted up. So here the stellar ring is actually thicker than usual. So that is how you define tilt. So here you can see that if you minus the stellar ring, that the neuroretinal rim is definitely getting thinner here. And in myopes, you usually do not get a deep cup, maybe because this patient had a very high intraocular pressure that the cup was also getting deepened. And you usually cannot appreciate the RNFL defects in myopes because of these RP changes, which what they have and the striations are not visible very nicely. So this is what I was going to trying to tell here, that this is a stellar ring, which you should not be including in the estimation of the optic disc. And this is the inner margin of the scleral canal. And this is the neuroretinal rim, which is pretty thin. But if you include this as the margin of the optic disc, then you might falsely feel that that my optic disc has pretty healthy NRR when it is not. So even if this patient had pressures not very high, 1920, she had cataract, and the patient did not belong to the patient was poor. So in this case, even in undilated, if you would not dilate the patient, you will not be able to appreciate the exact changes that is actually happening in the fundus just by looking at the optic disc. Okay, there is some thinning that is being noticed superiorly. But when you dilate and examine, and you see that, you know, the patient already has formed such wedge defects both superiorly and inferiorly. So if the patient, you know that the patient may not be able to afford drops to be put in the eye, then you know, you can discuss the surgical alternative also for this kind of patient. So just by good examination, because you know, okay, if this much of which RNFL loss has happened, then definitely this patient, I mean, already has moderate glaucoma. Like this is another example where if you look minutely, if you look at the the neuroretinal rim, you can see that there is some irregularity which is forming here. So corresponding to which you can also see an RNFL defect which is forming. So what I want to say here is that, you know, it is so important to examine the neuroretinal rim, the rim of the optic nerve, you know, and that is what will give you the clue whether my patient does have glaucoma or does not have glaucoma. So this is a 39-year-old Taylor. You can see the pressures are not very high. If you look at the disc, looks pretty healthy. But actually, when you dilate, you can see this RNFL loss which is present, and that actually confirms your diagnosis. No, this patient is definitely having glaucomatous damage, and whatever pressure. And on the other eye, if you see, it looks pretty normal, but you can see that there can be some amount of bearing which is here, but you're not sure. But when you dilate and see, when you can see this defect, then you know that this patient is definitely having some early changes of glaucoma. So if you ask about the myopic eyes, the myopic eyes are tilted, they can be torted. And so here comes the importance of the contour cup. So this patient had hand movement and pressure was very high. The other eye was okay. I mean, so you can see that, you know, here the vessels are bending all in the edge. So that is what you're going to use here, because the color is not very good enough to tell you where is my neuroretinal rim, but where the second bend of the vessel is, you'll take that as an indicator for the size of the cup. So you can see here that is almost bending at the edge, and so this person has got advanced glaucomatous damage for which his vision is hand movement. On the other hand, even the left eye optic disc is highly torted, but then you can see that if you look at the bend, you can see that it is still here and the neuroretinal rim is still healthy. In this patient, because of the large peripapillary atrophy, you might get some enlargement of the blind spot. Now coming to the non-glaucomatous optic atrophy, like, you know, you may ask what is the normal color of the disc. The normal color of the disc is usually a salmon pink, and it appears like that because the nerve fiber layer acts as a fiber optic cable which transmits the color from the deep capillaries to the viewer's eye. So a crowded optic disc will look more hyperemic than the myopic disc, which may look pale. So where does the pallor come from? So whenever you have optic atrophy, actually their axons die. So they are replaced by the glial cells on the disc surface, which does not reflect light, and that is why you see this pale color and you do not see. So there can be some capillary dropout also, and the arterioles also, they reduce in size and number. So that is also the other reason that you see this paleness of the optic disc. So the difference between a glaucomatous and a non-glaucomatous optic disc is that, so both of these discs would look pale, but in a glaucomatous advanced damage, the paleness comes because of the absence of the neuroretinal rim. So, but on the other hand, if it is a non-glaucomatous optic atrophy, you can see that there's still some mass that is in the optic disc, and it is not because of the loss of volume, but the volume is there, but it looks pale. So, and but if you look at the RNFL, so both of them might have a diffuse loss. So from the RNFL, you will not be able to make out in advanced cases which is glaucomatous or non-glaucomatous, but the optic disc will definitely tell you the tale. And if you look at the OCT images, a glaucomatous optic nerve will give you a definite biarcuate pattern of loss. So this is typical of glaucoma until there's a very advanced damage. Whereas in a non-glaucomatous optic atrophy, you'll get a diffuse loss of the RNFL. It will not follow any pattern. And in obviously in a glaucomatous visual field, you will get these arcuate defects where the center may still be spared till the end. Whereas in a non-glaucomatous optic atrophy, you'll get this typical longitudinal defect which will respect the horizontal meridian. So the causes of a non-glaucomatous optic neuroatrophy, like, you know, can follow after having an episode of optic neuritis. So what is important in the non-glaucomatous optic atrophy are the history. I think it's very, very important. Like if the patient had this kind of an atrophy because of optic neuritis, now the patient will complain of loss of central vision with a dull retrobulbar pain. And in this kind of patient, it's very important that to do a color vision testing, the loss of contrast sensitivity, And RAPD can be assigned in both glaucomatous and non-glaucomatous in the advanced stages. So, but in optic neuritis, RAPD is definitely the sine qua non. The second cause for a white pale optic disc can be an arteritis ischemic optic neuropathy. But again, here you will get typical history of a headache, scalp tenderness, jaw claudication, ear pain, and the patient will give you a history of sudden painless vision loss, which never happens in glaucoma. Also, if the cause is an arteritic cause, then the patient may also give you a history of transient monocular visual symptoms. And so in the initial stages, this kind of patient will have a swollen optic disc with maybe some kind of flame-shaped hemorrhages in an RAPD. And the D feature of an arteritis ischemic optic neuropathy is a chalky white edematous disc in the initial stages, and which when with time may undergo some loss of the neuroretinal rim and may appear like a glaucomatous optic disc. But obviously in this kind of patient, you also have to take the intraocular pressure as a consideration. The visual prognosis in these cases is very poor. So in this kind of an optic nerve, which is because of arteritis ischemic optic neuropathy, the vision is very poor. But in case of glaucoma, even if you have a little bit of rim that is left nasally, the patient will be able to still read a 6.6 and 6.9, though in a tunnel way, but they will be able to. The third cause is a non-arteritis ischemic optic neuropathy. So these are the discs at risk. Okay, so this usually happens in very small optic disc with no cup. So when so many axons go through a scleral tunnel, they have exoplasmic stasis, and so when the axons swell up, they further lead to more ischemia, and then you get a picture like this. So this kind of patients also have a vasculoparetic risk factors like in hypertension, diabetes, hypercholesterolemia, any vasospasm or impaired autoregulation. Here, the losses typical you may feel that the superior and inferior part, of the neuroretinal rim is appearing pale. And this kind of patients will have a typical altitudinal defect. So you can also get an NAI in a PECG patient. Like this is a 41-year-old male who has bilateral primary angle pressure glaucoma where the pressures are controlled at 3 AGM. So here you can see that normally whatever pictures I have shown you till now, I have shown you that that the neuroretinal rim in a glaucoma patient, unless and until there's something else, they're usually pink in color, unless until the patient is myopic. So, but in this patient, the patient had high intraocular pressure and the neuroretinal rim is also appearing a little pale. So these are the patients when the pressures are very high, some kind of ischemic event had set in, and you get a picture like an NAION. In this also you get the OCT also confirms the diagnosis that there is a diffuse loss of the retinal fiber layer, and it's not in the arcuate pattern. And you can also see that there is biarcuate scotoma in the right eye and inferior arcuate scotoma in the left eye. With an incomplete arcuate scotoma and superior in the left eye. So by looking at the fields, you know that the left eye field is much better, whereas a 10-2 is better in the right eye. It's good in the right eye. So this is another lady who had high pressures in the left eye, had an attack of glaucoma, and then you can also see that the NRR has become pale. So in any patient of glaucoma, if you feel that pressures are very high but still they may have some kind of paleness of the neuroretinal rim because of the ischemic event that had happened when the pressures are very high. So here you can see that the right eye is normal and the left eye has got a diffuse RNFL loss, which is also confirmed by the field test. So in cases of neurological field, you may just get some temporal pallor, and you have to take care of the age also. In a young patient, maybe the vision is decreasing and there's any other reason to it except this temporal pallor, and corresponding to which you can also see this RNFL loss that's happening in the temporal quadrant. And then when you do a visual field test, you get this visual field which respects a vertical meridian. I think that is the typical sign of a neurological field when they respect the vertical meridian. So any optic nerves where you feel that there's some amount of pallor which is there, just get a visual field test done. It'll tell you if the visual field is respecting the horizontal meridian, the patient will have ischemic optic neuropathy kind of finding, or if the patient is respecting the vertical meridian, that it may be neurological. So this is a typical bow type pattern of pallor that you get in neurological field where there's some chiasmal lesion. So again, you can see that in the field test, it's respecting the vertical meridians. The next differential diagnosis would be a traumatic optic neuropathy. Obviously, in this case, there may be some amount of vision loss depending on what was the severity of trauma, and it's typically unilateral, and definitely the patient will have a history of trauma. So the patient will also have decreased color vision, visual field loss, which may not be very typical. I mean, they can be central scotomas, or they can be centrocecal or altitudinal. So it depends on what kind of damage the optic nerve has suffered that you'll get a corresponding visual field. So here you can see that some amount of pallor has set in, but otherwise the patient is 6'9" and there are hardly any changes. Next comes your nutritional toxic optic neuropathies. Here, I think it is the history is very important. That bilaterally the patient will complain of decreased vision, which is painless, progressive, and obviously if you delve further into it, you will be able to get the nutritional and the toxic, the history of the patient, the medication the patient is on. And when you examine the optic nerve, I think the most important is you get a temporal pallor in these patients. So you get a temporal pallor in bilaterally, and as you can see with the OCT also. And I think in a nutritional toxic optic neuropathy, the centrocecal scotoma is the most prominent, the type of field defect that you get. Then the other mimics optic atrophy, like an optic nerve hypoplasia, suppose in this patient may be referred to you because of this paleness of the optic disc, but actually this is not the optic disc, this is the sclera, and this is the actual optic disc, which is very, very small in size. This is another one, the morning glory syndrome. You may feel that, that this is a large optic disc, maybe glaucomatous, but it is not actually. So morning glory syndrome is very, very, it is typical of itself. Like here, it's not the optic disc. Actually, the optic disc is, it's submerged into this excavation. And you can see this blood vessels just like radiating from the optic disc, and you can get some glial proliferation. You'll get this peripigment, pigmentary problems. And the next would be an optic disc pit, where the dysplastic retina has actually gone behind through a collagen line pocket and maybe in contact with the subarachnoid space. So this is just a depressed part in the optic disc. And this is not a double optic disc, but it's an optic disc coloboma, where the optic disc, like it is an excavation which is present off-centered but involving the optic disc. This implies incomplete embryonic closure, incomplete or an abnormal embryonic closure. The last is the this metilated nerve fiber. Obviously you not miss it. You not consider it to be glaucomatous, but this is one of the whiteness around the optic disc. The typical feature is a feathery margin, and the vision is normally retained, but except in very severe cases, the vision may be low. So I would like to conclude that evaluation of the optic nerve is very important for the diagnosis, whether it's a glaucomatous or a non-glaucomatous optic atrophy. Very, very good history and a very good clinical examination including the pupil reaction, the color test, color vision test, the contrast sensitivity. I think it's very important to know what the etiology is. And it is also important to find the etiology in patients with non-glaucomatous optic atrophy, because if one eye, it has happened in one eye, the other eye is always at a risk. I think that is it from my side. We can take questions now.
Thank you, Dr. Julie. I think it was a really lovely presentation. You covered, you can stop sharing your screen. So you almost covered everything from how to diagnose glaucomatous discs till to all the possible most common differential diagnosis, starting from the compressive optic neuropathy, traumatic, ischemic, even congenital. So most of the topics were covered. There's a very interesting question. In fact, I am myself very confused about what is the gamma and delta zone of peripapillary atrophy. To verify, I don't know the answer. If you know the answer, you can
So usually there are alpha, beta, gamma atrophy. Nowadays you get this delta atrophy also, which you can see in this myopic eyes, where if you do so, the alpha atrophy is like where there is it's just a zone of hyperpigmentation. The beta zone is a zone where there is RP abnormality and with the thinning of the choroidal tissues, and where you can see the base layer. And you can also see the choroidal vessels which is going through it. And the gamma and the delta, I think, are the atrophies which you see in advanced myopic damage. Where I don't know the exact definition of it.
Maybe we can. I'm not sure whether this question will be asked in exams also, but for practical purpose, I don't think this gamma or delta is very important from clinical point of view.
Nowadays, it is that the gamma and delta zone are important if you consider a myopic eye, because if you do a choroidal angiography, there it is important, because if you do an OCT angiography of the choroidal blood vessels and there you see some loss in the delta zone, then it is more characteristic of glaucoma. So that is how.
Thank you so much. Ronnie sir, so there's another question for you, like how you classify the fast and slow progressors on perimetry. And I think the newer perimetry machines, they have got this liquid lens system. Anything you want to mention about that?
Yeah, so a couple of things. One, slow and fast progressors, a typical average glaucoma progresses around 0.5 to 0.6 decibels per year. Anything more than that, or anything more closer to 0.1 decibels or more, would be considered a fast progressor. Anything that progresses at the normal rate is a slow progressor. In terms of the liquid lens, so typically what you do is when you're trying to correct for the refractive error in a visual field, you put full field lenses in the lens holder. With the liquid lens, you can correct spherical errors using it automatically deforms a liquid lens to give you that power. So you don't need to change lenses for in between cases, but significant cylinders still need to be corrected.
So there is another question, when the pathology in glaucoma mainly affects the axons from the level of lamina cribrosa, due to which we see all the characteristics this changes, why the RNFL loss or thinnings occurs from periphery to center?
Should I answer that?
Yeah, sure.
Yeah, actually, if you see they come from the periphery and they converge to the optic nerve, right? So in the periphery, obviously the density of the RNFL is less than in the optic disc. So whenever you have a damage, so the damage is more, so it starts from the periphery. In the optic nerve, because of the density, it is not appreciated. Suppose we have a thick layer. So if the deeper layers are getting damaged, you are still not being able to appreciate it. Whereas because of the thickness of it in the periphery, so even if there is a loss, you'll be able to appreciate it much better and much sooner. So the defects do appear from the periphery towards the center, and sometimes, so in a very early stages, the defects actually may not converge onto the center. So it's very progressive. So, I mean, people who are really good at examining the RNFL, they would be able to pick up very, very early defects, where the defects are forming from the periphery but have not yet reached the optic disc.
And another question for neurological cases, Dr. Julie, what type of perimetry you are using? Whether you use 30-2 or 60-4, what is your preferred?
We usually use a 30-2 because there is a neurological field defect. You can very well see this 30-2 also.
Any particular case you like to consider using 60-4?
I mean, we usually do not use 60-4. What about you, Dr. Ronnie?
No, we don't use 60-4 either. We use a full field 120 occasionally.
For which cases, sir?
Out there in the periphery.
Okay. So sometimes for driving and all, is there any role of perimetry for driving, for fitness for driving?
Yes. So as of now in India, they don't insist on visual fields for driving, but in many parts of the world, they actually insist on binocular visual fields, which they have criteria for, especially in UK. So Yes, visual fields are important from a driving point of view, but in India, we really don't have that issue.
For that, I think we use that estimate binocular perimetry.
Yes.
Dr. Julie, there's a question for you that in a patient with disc pallor, what are the tests you will consider? So if there is a temporal pallor, what is its significance and what investigation will you advise if you get a patient with a temporal pallor?
So it starts from the history, what the patient, what is the history of the patient, how did the vision loss was, whether it was a sudden loss with pain or without pain, whether it was progressive, non-progressive, and obviously the clinical examination, you'll be doing a good pupillary reaction, and you'll be doing a color vision test and a contrast sensitivity test. And based on if you feel that the typical temporal pallor would be found in nutritional and toxic optic neuropathies, okay, and you can also get this kind of paleness in a compressive optic neuropathy. So maybe a visual field test will give you a good start to how the investigation should be.
So
And based on the
so it's a complete evaluation. But in every patient with temporal pallor, will you consider doing a baseline fields just to sort of?
Any patient with any amount of pallor, the simplest that you can do other than the clinical examination is a visual field test.
And then depending on other findings, you will go for further investigation like neuroimaging and all.
At least clue what a diagnosis is, or is my vision threatened? You get a lot of information from a visual field, at least in our paid optic test.
Thank you. So Dr. Ronnie, sir, there is a question that what is floor effect? I thought it's more related to OCT, but anything in fields, I'm not sure about it.
Well, theoretically, you can have a floor effect in fields also, because suppose you have something which is
you
for
can't
example,
go lower than zero.
Go all the way to zero apostips.
Mm-hmm.
So then you can have a floor effect because you cannot check below 1000 apostips.
And there was also a question, what is the relationship of apostip and decibel?
Yeah, so apostips are an absolute value, as I mentioned. And decibels are actually a value that the manufacturer gives to a particular apostip level. Okay. So for the Humphrey visual field, your values range from 0 to 10,000 apostips, where 10,000 apostips is 40 decibels, and 0 apostips, where 0 apostips is 40 decibels and 10,000 apostips is 0 decibels. For octopus, that goes from 0 to 1000, where the 40 decibels is typically 0 and 0 is 1000.
And why there is a blue-green color defect in glaucoma, although it is an optic neuropathy?
You don't really call it a blue-green color defect. There have been color vision, mild changes have been reported in glaucoma. If you're referring to the blue on yellow pathway, which was supposed to be damaged early in disease, that is basically related to the fact that a certain subset of the ganglion cells which are responsible for that pathway were supposed to be affected early. More recent data suggests that blue on yellow may not actually detect glaucoma earlier than white on white perimetry.
Okay, I think we've covered most of it. There's another question of trigger happy patient, the patient with high false positives. So I think most of the questions have been covered. So thank you so much, sir. And thank you so much, Dr. Julie. It was lovely. There are a lot of new things we discussed. And I'm sure for PG, this must be really useful because perimetry is extremely vital. The more you listen to perimetry is less because you need to keep learning perimetry more and more. And Dr. Julie has covered in detail almost everything about glaucomatous and non-glaucomatous optic atrophy. So thank you so much. And Dr. Satyajit, I'll hand over the mic to you.
Thank you so much, Dr. Maneesh, for moderating it so well. It was a pleasure and a treat listening to Dr. Ronnie George and Dr. Julie Pegu for the wonderful presentation that they have made today. I have an announcement for the postgraduates who are listening to this webinar, is that we are getting an increasing number of emails to send the recordings of the sessions that are happening over here. Now, it is very, very difficult, the office man hours, with the office man hours and with the limited office people that we have, it is impossible to send these videos henceforth from today. It would be best you tell your friends and yourself also, please try to attend these meetings which are there every day at 5 o'clock. We are trying to figure out a system in which we will see, we have a attendance over here. We can see everybody who is every day who is attending, and we have the list. And when we see, just like Humphrey Field's repeatability, and those postgraduates who are more over here, and we understand that they are more interested in this program, at the end of the program, we will try and send them these recordings. It is virtually impossible for me to send recordings of this to every day, 50 to 100 emails to reply. We cannot do that, and we will not do that from today and tomorrow onwards. So please request all your friends, all your postgraduates to please attend this class, because we have the very best from the country over here. A lot of time, effort, energy, and this thing has gone into bringing this all together. And it cannot be simply just done by sending an email, and please send me the recording. So even you have to make an effort to be here at 5 o'clock and listen to the questions. And most of all, it will be advantages that you can ask the questions to the top class faculty who are presenting. You will not get this opportunity again. So once again, I'd like to thank Dr. Ronnie George for the amazing presentation. His time, he is very busy, and we are very grateful to him for his time. We are very grateful to Dr. Julie from Shroff Charity Eye Hospital. I know your OPD has already started and you are busy with your patients. Dr. Maneesh, who is religiously helping me every day. And I would say not helping me, but helping all the postgraduates worldwide in conducting this program. And your efforts are benefiting so many people. Thank you so much, Dr. Maneesh. Thank you, all the participants. And tomorrow, I'd like to request all of you to be here, because we will not be able to send the recordings. Thank you so much, everybody.
And sir, tomorrow we have presentations on OCT in glaucoma by Dr. Sunita Dubey from, again, Shroff Hospital, and Dr. Parivardhini will be speaking on optic disc imaging, HRT and GDX. So there are another two very exciting presentations. Personally, I'm very excited about all of this. So I'm sure as a PGT, I think it's a great boon for them to getting a chance to listen to such lovely presentations. So thank you again, sir. Thank you, Dr. Julie.
Thanks, Maneesh. Thanks, Satyajit.
Thank you, Dr. Ronnie. Thank you.
Thank you so much, Satyajit. Bye.